Hello and welcome back. This is lesson 8. So in this lesson, we're going to talk about advanced CT applications because we do have that in CT where we kind of go beyond just the regular, workhorse of, head CTs, abdomen pelvises, and PE studies. So when we talk about advanced applications, we're talking about like our 3D reconstruction, MPRs. Like I said in a previous lesson, we use your axial thin data set of images to create a coronal and sagittal reformat. So those images are overlapped on top of each other, where they're stacked overlapping, so that you create this really nice picture of a sag and coronal. So these are not contiguous, these are overlapped. So usually when I say overlapped, the thin data set could be like a, for example, 0.625 by 0.3 or something like that. Okay. So they're all these images just overlapping each other. Now, multiplanar reconstruction or MPR. This is used for every CT study image. Every study, every protocol requires a sag and coronal so the radiologist can see all the different views. Okay, not only axially, but coronal and sagittal. Now, you also have something called a maximum projection intensity, or your MIP. This is used to highlight the vessels, like we use it for CTA exams. We use it for like high-res chest. We use it for, PE studies, chest CTs. So it really enhances, like if you gave contrast, it enhances all the vessels so the radiologist can see it, and it enhances all the structures of the chest and the bronchi as well. Now, like I said, overlapping thin images are used to create these 3D volume rendering and these sag and coronal reformats. So just make sure, and usually every protocol is built with that so that you automatically have that so you can go ahead and reformat that after your exam is done. So make sure that your protocols, so I would check your protocols, that you have that thin data set. I know there's been some places that I worked that I actually had to create them after I was done. It just took a matter of, hey, let's put this in our protocol so we can have our workflow be a little bit more streamlined. And of course, CT images can be reformatted in any plane. So we can do an oblique plane, we can straighten our image. That's the beauty of, this type of imaging and just the way technology has evolved and advanced. Now, CT angiography basics. So our CTA exams. Of course, we use it to highlight arterial vessels in the body. So typically these are ordered for stroke, PE, mesenteric ischemia, peripheral artery disease on runoffs. And of course, 18 or 20 gauge AC lines are the preferred method of access to receive an optimal exam. Of course, we can use power central lines, power ports, power PICC lines to achieve this as well. I will stress this. Please do not use EJs, IJs. Those are a big no-no. You can compromise the patient's airway. So if you're doing this, stop. Do not use these forms of accesses because they are dangerous. Remember, this is a line that's going into the patient's jugular. So we are not going to do that at all. I have seen where physicians have pushed to use this line and technologists did, and the patient's airway was compromised and it was messy. Do not use an IJ, do not use an EJ. Those are big no-nos, okay? Now, your 3D and MIP images are used to visualize the vessels for clinical diagnosis, okay? These are very important because we do these for just about any CTA exam. Standard practice, standard procedure, and, radiologists really want us to make sure that we do these. Now, what I found to be very helpful to memorizing vessels, memorizing the different types of arteries and veins that we're looking at, especially, referencing them to CT images, is using a sectional anatomy book, or those anatomy coloring books are so good. I know I used them when I was taking anatomy and physiology. I know I used a anatomy coloring book, just as a reference when I was learning CT. They're great and it's a great investment. Now, we also have cardiac CTA. So these are used for patients who have, coronary artery disease, maybe an abnormal stress test, unexplained chest pain, things like that. These will typically get ordered where we have to hook up the patient to an EKG, make sure that they have an 18 in the right AC because that is preferred. Typically, these are ordered to avoid patients having a cardiac cath procedure. Now, this is not to say that if this exam is positive that they won't have that, cath procedure, because sometimes there's a small percentage of patients that Yes, they couldn't either rule out what was going on or something was positive on their cardiac CTA, and the cardiologist opted to take him to the cath lab anyway. I've seen instances where that does happen, okay? But normally they do this to avoid getting poked and going through that whole procedure. Ideally, a heart rate between 60 to 65 beats per minute is ideal. If they can get it lower, that's even better. Typically, I think at my facility, we try to strive for like that 55, 60 range. It's not always possible, but we do try. And our cardiologists, the interventional cardiologists, are very heavily involved in that practice when it comes to that. A calcium score is usually done prior to the CTA. So they do the calcium score to measure, and they use the Atkinson score to measure how much calcium is present in the patient's cardiac vessels, which I have an entire course on cardiac CTA that kind of dives into that. So I'm just kind of giving you a general perspective. Now, an RN is present to administer medications. They have to be there to administer medications as the low pressor, which is your beta blocker, and the nitroglycerin. So beta blocker to lower the heart rate and nitroglycerin to open up those arteries so contrast can flow through it a lot better for better enhancement. So we always have to have an RN present for that. Now, there was an instance where I did have just a radiologist present. I worked at a facility that this radiologist was trained in cardiacs, and he administered all the medications and was there for the entire scan. This radiologist was great because he did his own workups too. So all we had to do was the scan. That's it. Start the IV, make sure that the patient, took the low pressor because it was oral low pressor before they got on the table with the radiologist present. And I mean, it was like the easiest cardiac CTAs we ever did. Okay. But normally cardiologists are the ones that are involved with these exams. Now, sometimes you might work at a hospital or at a facility that you have a radiologist that has that specialized training in cardiac CT that will intervene and read these and be present for those. I've only worked at one hospital that happened at, but it does exist out there. Now, we also have evolved into dual energy and spectral CT. So dual energy, this is imaging with two different X-ray levels, X-ray energies. So what I'm talking about is you have two kVp settings, so like 80 kVp and 140. There are some systems, such as like the Siemens 128 dual energy CT, that will have the two X-ray tubes that rotate. They rotate. One rotates one way, the other one rotates the other way to make dual energy imaging possible. At my facility, we have two scanners that do dual energy scanning. So there are some CT machines that'll have the two X-ray tubes. Typically, this dual energy imaging is used for stroke patients, post TPA, TNK, because I know that's what they call it now, or IR intervention if they're given the intra-arterial TPA. So what this does is our protocol is set up where it separates the iodine from the water to better visualize the tissue structure. So that is how our protocol is set up at our facility. So it's very detailed. So this imaging can only be done on systems that have like a 128 detector slice or higher. So at my facility, we have two 256 GE scanners. So dual energy is only possible when you have a higher detector slice. As far as I know, it doesn't exist on the 64. I could be wrong, but I know I've worked at a lot of hospitals, and every 64 that we have, that protocol does not exist. So from what I understand, it has to be a 128 or higher. Now, there's something that I know personally I haven't worked with because I haven't had a facility that does spectral CT, which is capturing the X-ray photons at different energy levels, and it improves your image quality and tissue definition. So you've heard it probably called as photo counting. So it reconstructs multiple energy spectra in one single scan. So this improves your contrast resolution and it really reduces your artifact. I know there's some systems out there that this is possible. I haven't personally worked on it. So, and of course, I know there's, SPECT in nuclear medicine, which is kind of similar to this, except this is kind of built into, the whole CT design. Okay, so this is the end of lesson 8. So this, just kind of giving you a general overview because as a new technologist, I don't want you to get overwhelmed, but you need to know just kind of the basic stuff and just kind of a crash course of things, right? Now, in lesson 9, we're going to talk about troubleshooting and problem solving in CT. So stay with me and I will see you in lesson 9.